Welcome to the Health Impact Hub's podcast, The Hub. This is a space where we highlight the voices of those shaping the future of health, not just in clinics and hospitals, but across communities, classrooms, and policy spaces. Each episode, we talk with leaders working at the intersection of medicine, public health, and policy to tackle some of the most pressing issues of our time, whether that's through advocacy, innovation, or grassroots action. Welcome to The Hub.
Hello.
Hello, Phelan.
How are you today?
I'm okay today. How are you today?
Fine. Thank you for agreeing to do this.
Of course.
Mhm.
My pleasure.
So, for everyone watching this or that is going to watch this, Dr. Bruce Link is an epidemiologist and sociologist who is a distinguished professor of sociology and public policy at UC Riverside. He's also a professor emeritus of epidemiology and sociomedical sciences at the Mailman School of Public Health at Columbia University and a research scientist at the New York State Psychiatric Institute. He also developed the fundamental cause theory of health together with Dr. Joe Phelan, which we'll be discussing today. Thank you for being here with us today, Dr. Link. For those
Good.
unfamiliar with your work, could you briefly explain the fundamental cause theory?
Okay, that might not be a quick answer, but here goes. I mean, one of the most interesting observations from epidemiology over time of the connection between socioeconomic circumstances and health and mortality is that it's been persistent. That is, it's been around for a long time, historically. It tends to be present in very different circumstances in Europe, in the United States. And so this persistence poses a need for an explanation about why that association should be so persistent, such that people with higher socioeconomic status have, for example, lower mortality than people with lower socioeconomic status. And so the fundamental cause theory, and the reason that's so striking is because over time, the diseases have changed, the risk factors have changed, the protective factors have changed, and yet the association's persistent. Now, how could that be? And so fundamental cause tries to explain that persistence. And it does so by identifying factors that we call that are fundamental causes because they're related to multiple disease outcomes through multiple risk factor mechanisms that replace over time. So you have to ask, why do they replace? Is that just why diabolical magic or something? Some evil spirit always coming through to disadvantage poorer folks and people in disadvantaged circumstances? That's not satisfying. So what is it? So we identify what we call flexible resources. And we call them flexible resources because they can be used in different places and at different times, no matter what the risk factors are, no matter what the protective factors are, no matter what the diseases that are extant in the population are at any given time. And these flexible resources are things like knowledge, money, power, prestige, beneficial social connections. And that people use those resources when confronted with challenges of health or how to protect themselves. And people with more resources are more able to access the protective factors and stay away from the risk factors, no matter what those risk and protective factors are at any time. So the association reproduces itself.
Thank you very much for that.
All right.
Yes, I was going to actually ask what the difference was between flexible resources and protective factors.
Flexible resources and protective factors. Well, the protecting factors would be things like getting a cancer screen, a vaccination, implementing a good, healthy diet. Those would be protective factors. And then the idea of flexible resources are things that influence whether you're adopt those protective factors.
Okay, thank you very much for that.
Okay.
So how do you think the fundamental cost theory has evolved over the years or has been validated, especially with the recent COVID-19 pandemic?
Okay, so one thing about when you construct a theory or an idea, you always want to look at places where you can test its truth value, because you don't want to be putting forth an idea that doesn't cohere with predictions or facts. So with fundamental cause, we've tried to do that, and we've come up with multiple ways of testing the theory. One of those is to look for circumstances in which our ability to prevent disease changes over time. So you can take a disease like colon cancer, and at a certain point in time, we didn't know that much about how to address it. But recently, we've come up with a lot of protective factors, colonoscopy, things like this. And then when that happens, then the prediction is that when people have the opportunity, it becomes possible to use your flexible resources, then an inequality by socioeconomic status emerges. So your prediction over time is that at a time when you didn't know what to do about a disease, there could be an association with SES, but it might be that higher SES people don't know what to do to protect themselves. And so before you develop the protective factors, you don't have any way of using your resources to protect yourself. But when we develop the wherewithal to prevent the disease, then even though it sounds ironic, but then that generates a health inequality because people with more resources have more opportunity to access those new beneficial circumstances. So that's one where you have changes over time. Another is static, right at this point in time, and thinking about across all diseases. Some diseases are highly preventable. Lung cancer is, for example, by stopping smoking. Heart disease has become more preventable over time, but other diseases are much less so. So things like brain cancer, pancreatic cancer are much less so. So you expect that when a disease can be prevented, then the SES association with education, income, occupation as SES, that association will be stronger for diseases that we know what to do about. But for diseases that we're clueless about, you can't use your resources. So you expect a smaller or no SES gradient. So you can test and see whether these predictions are supported by studies. And so a lot of studies have tried to use those tactics to try to test the theory. I can give you one more, but maybe that's enough. And then COVID is a really good example. It's not like you set up COVID as a test of fundamental cause theory, but in a sense, it kind of is. It's passing through our population because fundamental cause theory was developed before COVID existed. So it had the prediction that when people have the wherewithal to protect themselves, then the SES gradient should emerge. So then COVID comes along, and fundamental cause can make a prediction about what might happen. And especially has that disease happened, where did it start? Well, it started and came into the US and around the world from world travelers, from people who were on cruise ships, from people who went to Italy to go to high-end skiers. The disease first hit the elites because they're world travelers and they got exposed. And the virus was perfectly happy with that. Anybody would be okay with the virus. But then, and at that time, the rich folks and the well-heeled and those who have a lot of resources didn't know how to protect themselves. They didn't know the disease was amongst them. With time, they figured out things to do to protect themselves. And that would be social distancing, staying home, work from home, not live in crowded circumstances, have other people who get your groceries for you, all sorts of things that go to your vacation house, move into the woods, to a fancy place on Airbnb. All these things are things that richer people did. And sure enough, the COVID mortality spread more rapidly among people who couldn't do those things, among poor folks. And it's sort of as if you had this new disease that we didn't know about, came into the population, and at first it's agnostic to where it goes, but then it gets introduced to inequality, to American inequality. And when it gets introduced to American inequality, because of processes associated with fundamental causes, it comes to be shaped just like many other diseases that we experience, such that our rates are higher, the mortality is higher in poorer folks than in richer folks. So it's circumstances like these, when you think about them from a fundamental cause kind of perspective, makes you think, maybe there's something to this idea.
That's very interesting. Okay, so there's widespread support for expanding access to health insurance as a solution to health inequities. Are there instances where this may appear to reduce disparities, but actually deepen these inequities in the long run?
Well, that's an interesting question. I'll say a couple of things. One thing is, and I think people from my discipline, they might not be doing it as much now as they used to, but they used to kind of discount the importance of health services in producing health inequalities. They were important, but there was all these other things that mattered for your health that weren't about your interactions with health providers. On the other hand, it's absolutely true that your access to protective factors is deeply influenced by whether you have good insurance, for example. And so whether you get the cancer screens, whether your blood pressure is well managed, all those things do exist, and you receive them from your healthcare circumstances. So we don't want to underestimate it at all. It matters greatly. The only way that I think that getting access to healthcare, the only way it could influence inequalities is by unequal access. If everybody got it, got the same circumstances in their healthcare, then that would no longer be a mechanism linking socioeconomic status or race and racism to health. So in general, it's one of the things that we need to address. It's important for more than just people's health. It's important for their financial security to have. So that's kind of what I think. You can do a follow-up on that question if you want.
Oh, okay. Because I was thinking more, I know this is your interview, but I had some thoughts about this question.
That's good.
I was thinking more the inequity could set in if the health insurance between different SES groups are maybe for low income people, the health insurance is not as meaningful as the health insurance the high income groups have access to.
That is what meaningful?
Yeah, if it's meaningful. For example, you have health insurance, but you don't have access to a good hospital or a provider that is willing to attend to you. So right. I think more of the question was policy focused on access to health insurance as the band-aid answer to health inequities. Do you think this would cause more inequities in the long run if a lot of the focus is on expanding access to health insurance as a solution? Yeah. because
Well,
it's a
yeah.
really popular option.
Well, I guess I think we have to do all these things. So we
Mhm.
want to say we should not focus on people getting health insurance coverage. But I think the point you're making is that we can get focused in on things that we think are the magic bullet when they're not at all. And what you're saying, the principle you're articulating, is that if we focus too much on just access to insurance and then ignore all the other things that happen, that would be, by the ignoring of the other things, will allow the processes that produce the inequalities to occur. So we'd want to see if that actually happened,
Mhm.
but it's a good idea to have.
Okay, thank you. Mm. Are there any fundamental causes? Because I know the fundamental cause theory has been like around for a long time now. So with this research out and very popular, do you think there are like any fundamental causes that are still being left untouched by current policy?
In some ways, a lot of them are not sufficiently touched. We don't do enough in the domain of the things that make these associations get reproduced. We tend to focus on things that are downstream from that, on people's health behaviors and these kinds of things. Those are important to focus on. But if we wanted to reduce the inequalities, we would try to focus on things that are um, that are closer to what it is that causes these associations to be reproduced. So we would want to try to equalize the flexible resources in a population, or keep them from getting more and more unequal. Sometimes you think, well, geez, I can't make inequality go away. But we've been very successful at increasing the inequality over the past 20, 30 years. So there are policy actions that are occurring that are increasing that inequality. And so one of the principles of fundamental causes, we want to reduce that. And while it's not, and it might not be the public health person's sole responsibility to do that, because it has to do with so many other things. But nevertheless, that doesn't mean it isn't critical to the generation of inequalities. Did that make sense?
Yes, that makes sense. That makes sense. Okay. So, in your view, how do you think the medical health workforce and policy training, like formal training settings for medical and health workforce professionals, how do you think it should better integrate understanding structural determinants of health? Do you think there's a current gap in like many of these settings today in how they teach the students about structural determinants of health?
Yeah, okay. So I think there are really good models for this. And actually, our medical school has adopted a lot of them at Riverside. And the term that's been applied to this, it was actually developed by a couple of people I work with. They call it structural competence. That they try to, their idea is that they want to help providers have what they call structural competence. There was a set of concepts called cultural competence, but the view was those were not focusing as directly as they should on the social determinants of health. So there are really beautiful trainings they've developed. And if you take my class, I'll show you an example of how they take a situation and look at the complaint that the person comes in with, and then trace back to the sources of that, where that problem emerged, by locating the person in social circumstances and economic circumstances and so on. And then when you do that, you see more fully the situation that lies before you. Now, of course, you have to work fast in a medical context, so often you can't do that. But having the capacity to think that way about the problems that you're seeing coming into you is something that this group that is putting forth the idea of structural competence and trainings for it strongly believe in. And it's one, I find it exciting for a couple of reasons. One is that it's out there trying to do some good on the ground. And sometimes people like me can be too up in the clouds, but this is, doing something on the ground that relates to the kinds of things I talk about. And the other thing is part of what we need to do is to sensitize people in multiple circumstances about these phenomena.
I think my internet got cut off. I think it was me. I'm so sorry.
That's okay. I just made the most brilliant comment.
Oh.
I'm done teasing it. I was talking about the value of structural competence and that it's valuable because it's actually trying to implement practices that are going to help on the ground, but also it kind of trains people in influential positions to see these phenomena, whereas otherwise they might not. They're just clueless. They go in and do their job and they can't see where these things are coming from. And if more people see that, in the long run, over time, we get better at addressing them.
Okay, thank you. So that's kind of related to another question I have, which I'm going to ask now. So you discussed structural competence and spoke a bit about the process. Do you think there is a tension between communities and hospitals addressing fundamental causes and being cost effective? Or do you think that not addressing fundamental causes is actually like hindering cost effectiveness in the long run?
Well, I don't have evidence on this, so but I think it's a fabulous question. And the idea kind of is, the belief is that if you don't address the source of some of the problems, you have more expense down the road in terms of paying for the problems that emerge from the problem. So there's that kind of rationale to it. So the thinking would strongly support kind of like your premise there, that, or one of the premises you propose, which is if you don't address these more fundamental causes, does it harm cost effectiveness? And I would say the idea is that it would. Having someone come along and show it in a way that it does is, I don't have a great example of it. I mean, to some extent, the differences between our country and some of the European countries, where we spend much more but yet have, sort of worse health outcomes. It's consistent, and so they're doing more about the safety net issues and so on that are part of the fundamental causes idea, and their health is improving at a more rapid rate than the health of people in the United States, where we don't do those things. But that's not tight enough to securely say, that's right. It'd be a good project for someone to take on, to try to figure out whether or not you could find ways to test those ideas. And maybe somebody that has, but I'm just talking from what I know.
Thank you very much. So you mentioned like European countries. Do you think there are any models in the US that are doing a good job of addressing fundamental causes upstream? Any communities or models in the US?
Yeah. I mean, I don't know them well, but I know about them, and they try to kind of address these principles. Like the Cleveland Clinic might be an example, and our School of Medicine here is trying, to think that way, and so, which is a big attractive feature of it. and then to train people to be able to think that way, and then to bring them into the Inland Empire where we have health problems and sources of health inequities. So in some ways, that's an effort, whether it's carried through to have dramatic impact. But yeah.
Okay. Do you have any foreign model that is a standout for like addressing fundamental causes upstream?
Of some other country?
Yeah.
Well, like I'm going over to Scotland, and they've taken this up pretty seriously. And, they had worse health outcomes than some other countries in Europe. And they've really tried to implement a model that brings some of this to bear. And it's taking time. I'll find out, in a couple of months, some of their evidence that they'll present at this conference I'm going to about how they've been doing. But they very much conceptualized the problem that they face in terms of the sort of layered sequences of things that follow from fundamental causes. And they've tried to address them. But I'd say a lot of those countries do better than we do. And the evidence is consistent with that in terms of the consequences for population health. There's many wealthy European countries and Japan, Australia, Canada have all done better than the United States in terms of mortality reduction over time. Their life expectancy has gone up faster. We used to be in the sort of the middle of the pack, like rich countries. Now we're at the bottom. And part of the reason, and this again is not fully proven, but part of the plausible reason for this is their emphasis on some of the things that are more root causes. They address them. People don't have to worry about them. One of them is health insurance. Others are paying for college and all this kind of stuff. It could be stressful having strong policies for child welfare and things like that.
Okay. Thank you very much. So what advice will you give to students that are training in public policy and medicine so that they don't avoid falling into the trap of treating symptoms instead of systems? And not only like in practice, in policy and medical practice, but even when we're conducting research and disseminating findings. Do you have any advice for us?
Let's see. Well, one thing is to keep your frame of reference, to adopt a frame of reference that asks questions about the more distal sources of these problems, so that you have your eye to it. I think the idea of, what my class is health in all policies, to think about anytime you construct policy, even if it's not about health, you kind of also think about what its consequences for health might be. So with respect to housing policy, education policy, and on, think about the health consequences as you do your work in their different policy domains. I mean, you have other things to worry about in each one of those policy domains and other demands, but if you can just keep in mind health, it's going to matter for health too. And that is a value that many people have. And that if we can seek to maximize that in every policy, that will be helpful. So that kind of like lens as you go forward. In terms of research, it's kind of like, I think it's important there's a whole lot that hasn't been, research hasn't been done. But then it's very easy to fall into a very reactive to what's available to study. And a lot of the major studies that have been done and funded by the government focus most of their questions and inquiries on people's behaviors and their traits. And so there's a whole bunch of data about that. So people are drawn to looking into it. And there's nothing wrong with looking into it, but it might not be the things that you really need to, or it's not the sum total of what you need to. And something that's very, in my view, very absent now is how we treat each other. So it's so much is focused on how individuals behave and what their traits are, and are they conscientious and are they smart, and do they behave well with respect to health and all this. But to have a focus on what people do to each other, and so that a relational focus on these problems, because so for example, if you take like the immigration situation at the current time, and you think about the way in which this isn't, we can talk about people that are exposed to anti-immigrant bias, right?
Yeah.
And then try to trace through how it affects their health. But what I would suggest is we also need to find out who did it to them, who's doing it to them, why are they doing it to them, what are they gaining from it? So that focus on what other people are doing to invigorate the anti-immigrant bias is really important to do, to keep ourselves focused on that, as well as the consequences of being exposed to this. So that when we study people, and it's something like immigrant bias, we don't just ask, whether that occurred to you, but we ask, where did it come from? Who did it? But the other thing I was going to say is that in some ways, fundamental cause can be a little bit of a discouraging theory, because it says there are these factors that are, if you're not really working hard, are just going to reproduce the inequality. And it's going to pop up. It's like that game of whack-a-mole. I don't know if you know that, where you pound it down and it pops out. And then you pound it and it pops up again. It's kind of like that. And that can be discouraging. But the thing for people working in public health is that every little part you do matters, because this gradient can either be big or it can be less big. And when you go out and do public health action by trying to get people into good circumstances, to get them to cancer screening and so on, every little thing that you do helps keep that association, that gradient, from being bigger than it otherwise might be. So all of your action matters. It might not make it completely go away, but if you stop doing it, you just got discouraged, it would get worse. So it's very important that people stay and see that when they do these things, it does matter. So the public health action really does matter, even if it doesn't go back and get the root causes. It keeps those root causes from being as bad as they might otherwise be. So I'd say that, but I still also think that it's important for people in public health and medical spheres to think about the background social fundamental causes and keep trying to address them.
Okay. So I know that the fundamental cause theory has been, just like a question I do have, the fundamental cause theory has been around for a while, has been frequently cited in literature. So is there any interesting modification to the theory that has got your attention?
Oh yeah. I mean, actually it's very interesting. It's really grown, and people have expanded it and thought new thoughts about it. And so there are multiple ones. I mean, I'll tell you one of the important ones was to expand it to racism and stigma. So there, the idea was that even with your resources held constant, people who are exposed to racism and stigmatization have worse health. And so we added to fundamental cause racism and stigmatization of people as fundamental causes. And again, there you have to figure out, well, how does that happen? And then the idea there that we put forward is that people stigmatize other people to gain things they want. In other words, they use stigma to get things they want. So, and what are the things that they want? It might be many things, but we focused on 3 of them. Stigma and racism can be useful for keeping people down and so weaken them so that you can exploit them. So that's one benefit you can get from stigmatization and racism, keeping people down so you can exploit them. Another reason people might stigmatize is to keep people in so that they don't violate rules that you see as important. Mm-hmm. So that would be like bans on gay marriage. You're trying to keep people in. So that would be kind of like the keeping people in. And people want to keep people in, and so they'll use stigma to do that.
And social control.
There's control, yeah. Mm-hmm. Another way of putting it, keeping people in is wanting to control them. Mm-hmm. And then a third one is keeping people away, distance them from you so that you don't have to be exposed to them. And so the idea is that people get things that they want from stigmatizing others. Then they'll be propelled that if they got blocked in one effort to use stigma to keep people down, to keep people in, or to keep people away, they'll figure out a new one. And that's the fundamental cause idea there. And there's so many ways to keep people down in their way. There's so many ways to make people feel badly about themselves, like they don't belong, to have restrictive rules, to have the police surveil them, and all these things. That there's not just one mechanism, there's multiple mechanisms. And if one doesn't work, they'll find another one to achieve the end they desire. So that was a thing that was added to fundamental cause theory.
Okay.
That one's kind of like a positive one. Some other ones have been challenges. So the Latino health paradox is something that fundamental cause all by itself can't explain, because why does that happen? Also, women living longer than men is a bit of a thing that's difficult for fundamental cause to explain. That leads you to say, well, this theory doesn't explain everything, but it can explain some things. So it has to join with other theories to have a broader understanding. So there's that. And then one of the ways in which, especially with the gender difference in health outcomes with men dying younger than women, fundamental cause assumes that people value health, and health is really important. So they direct their resources to health. But people can value things more than health. Mm-hmm. Status, power. And so they can seek those things, even though doing so is dangerous. So that would be like in battle situations, in playing football. And men are more likely to do those things. So, so you have to take into account, what's valued most in the context. And so generally health people value health. So that's why fundamental cause can work. But in some circumstances, people are valuing something more than health, and they'll do things that are unhealthy in order to get that. I could go on about other things.
Yeah, I'm sure. Okay, is there a difference between institution-supported stigma and informal stigma?
My colleague, Mark Hatzenbuehler, who studied structural stigma, sometimes pits the structural effect against the interpersonal effect. And sometimes he finds that the structural effect is stronger. But other times people find that the interpersonal is more powerful, partly because we haven't fully gotten as good as we should at capturing the structural. We're better at capturing the interpersonal, better at measuring it and having it in tow. Because if you think about the structural, the things that we use are like some state policy or something like that varies. So, but anyways, I tend not to be a fan of trying to pit one against the other. I think they both work, and they're related to each other. And one produces the other, and the other produces it back.
Yeah.
It's yeah.
Okay. So, is there any particular idea, paper, or project you're working on now that excites you and pushes this conversation on the fundamental cost theory?
Yeah, I mean, I'm working on a paper with Cecilia Aon. We don't put it into fundamental cause framework, but if I was to, it would be on this stigmatization mechanism. We did a survey of immigrants to the United States, Black immigrants, non-Hispanic Black immigrants, Hispanic immigrants, and non-Hispanic Asian immigrants. We have samples of each one of those groups, about 300. And we asked them about their exposure to sort of the full cascade of circumstances that follow from anti-immigrant bias. I don't know if you know, Cecilia has scales she's developed. And then we brought in stigma measures of anticipating rejection, anticipating negative things like the fear that's going on now, picked up or treated badly. And then whether you internalize and you feel bad about yourself, and then finally your mental health. And it connects to the part of fundamental cause that's about the reproduction of mechanisms by a group wanting to keep people down in their own way. And the stigma is the enactment of that. And then it has these consequences that are harmful to the health of the people exposed to it.
Oh, okay. Thank you very much. So that was the final question. But do you have any other thing you want to say or any questions you have?
Oh, not really, but I'm curious what you'll do with this.
Oh yeah, we're going to put it on all our social media platforms because I'm sure you know about health impact health, right? Yeah.
Okay.
So I'm after doing this series where I'm trying to interview non-medical experts. Because I hear when people talk about health impact health, like I was trying to pitch it to like students at the School of Public Policy. And when many of them hear about School of Medicine, they're like, oh no, oh no. So I'm just trying to also pitch how different areas of policy also impact health. So that's really like what I'm trying to do. Yes.
Okay, good. Hey, well, good luck.
Thank you very much. Thank you. Thank you for being here with us.
Oh,
For having
sure.
me. Yes. And I'm definitely taking your class, so expect to see me there.
Okay. Great.
Okay. Take care. Bye. Have a good day.
Thank you for joining us for this episode of The Hub. If you enjoyed this conversation, please subscribe and share it with others who care about the intersection of medicine, policy, and community health. You can find us on Spotify and YouTube. To learn more or get involved, follow us on social media at Health Impact Hub. Until next time, thanks for listening. Music by Drake Maestas.